vascular morbidity and mortalities, and the timely identification and management can delay or prevent the progression to ESRD. While looking at the epidemiology, 30 to 40% of patients with diabetes develop kidney diseases. And in type 1 diabetes, it happens usually after 5 years, but in type 2, it is generally from 5 to 10 years. But in our scenario, in Indian population, most of the times, it may be present at the time of diagnosis because of the lack of awareness of diabetes in the population. DKD causes 40% of dialysis cases in developed countries, and the South Asians are at higher risk due to the genetic and metabolic factors. Now, what exactly happens in a diabetic kidney disease? When there is chronic hyperglycemia, it can lead to glomerular hyperfiltration and the production of advanced glycation end products, leading to activation of the RAS, and thus oxidative stress and inflammation occurs, leading to podocyte injury and GPM thickening, mesangial expansion and fibrosis, and in the end, there is albuminuria and progressive GFR decline per meter square. That is where the GFR declining is even more rapid, leading to an ESRD very, very quickly. Like I've explained before, our pathophysiology, due to chronic hyperglycemia, there is glomerular hyperfiltration and oxidative stress, inflammation, RAS activation, leading to sclerosis, fibrosis, and nephron loss. Now, what are the risk factors for DKD? Number one, as we've discussed, is the duration of diabetes and poor glycemic control, hypertension, dyslipidemia, smoking, obesity, genetic and ethnic factors. Now, what are the stages of diabetic nephropathy? The first stage is the hyperfiltration stage, where there is increased GFR, but this is a silent phase. Then comes the incipient nephropathy, where there will be a microalbuminuria, that is 30 to 300 mg per day. The next stage is overt nephropathy, where there is macroalbuminuria more than 300 mg per day. Then there is a progressive nephropathy, where there is a declining GFR, and the last stage is ESRD, where the GFR is less than 15 ml per minute per meter square. Now, what are the clinical features? For us as clinicians, we generally find these patients to be asymptomatic, and only during regular checkups or when they come with complications do we start seeing their sugars, their HbA1cs, and that is how and their KFT, and that is how we start finding that they might be going towards a diabetic kidney disease. Microalbuminuria is the first sign, and that is why urine albumin creatinine ratio is a must while you are screening patients for diabetes, or if you have a diabetic patient who has not had a UACR done, it should be done within the first 3 to 6 months, or maybe at the time of the time that the patient has come to you in your chambers. The first test that we should do is a UACR. Hypertension is also present along with diabetes. There are edema, fatigue, nausea in advanced stages, and in the late stages we see uremic symptoms. Now, for the diagnostic criteria, like I said, urine ACR is very important. It helps us understanding at which stage of nephropathy a patient might be and how we can try to get them treated as soon as possible. If the eGFR has been less than 60 ml per minute per 1.73 meter square for more than 3 months, that is a very big negative sign, and we should start acting on it immediately. We should also exclude other causes of CKD, which means that it is not necessary that it is just the diabetes that might be causing. There might be a coincidental intake of NSAIDs that might be causing. It can be other causes of CKD. So thus, history is also important in this. And we should confirm it with 2 to 3 abnormal values over a period of 3 to 6 months. In investigations, along with all the diabetic patients, we should get a serum creatinine check every time to understand how the eGFR of all patients are going on currently in the patient. And what happens in a very practical world is we just look at the serum creatinine. We see the serum creatinine being 1.3, maybe 1.35, and we say that it is normal, and we just ignore that fact and we just do not work up on it. Even I, as a starter in this field in diabetology, would not be too cautious when the eGFR was, if the serum creatinine was 1.25, maybe even 1.3 at times. But when we start seeing the sudden decline in eGFR or sudden rise in serum creatinine, is where we understand the importance of eGFR. And thus, if you get the serum creatinine, it is highly advisable, and it is the best thing to do is calculate the eGFR. It is available on all calculators, MD calculators, online calculators. Just enter the values and you will get the eGFR. Nowadays, even the labs provide us eGFR. So eGFR is a very, very important modality now for us to work up early and in the early detection of diabetic kidney disease. Apart from that, urine albumin creatinine ratio, HbA1c, lipid profile. Now, this is what we were discussing before I started at CMEA, is that fundoscopy is a must for all patients where we are looking at diabetic kidney disease, because nephropathy and retinopathy go hand in hand. अगर nephropathy है तो retinopathy ज़्यादा दूर नहीं, and the other way around. अगर retinopathy है तो nephropathy ज़्यादा दूर नहीं. And एक complication, if it starts, it is going to start the cascade of all complications. So it is best to check each and every complication, and thus fundoscopy for retinopathy, or even you can refer to an ophthalmologist and get it checked by the ophthalmologist to make sure that it is just either nephropathy or maybe there is a hidden retinopathy that is advancing now and we can take care of it early. Apart from that, we should get a renal ultrasound done to know the size and the echogenicity. Now, what are the management targets that we have to keep? We need to keep the target HbA1c around 7 or even below if that is possible. In advanced cases of CKD, medications are so limited and still they might not be as effective as we might think, and thus insulin is preferred in the advanced stages of CKD. We should avoid metformin if the eGFR is less than 30. Again, in our books it used to say if the creatinine is 4, then you should stop giving metformin, but now we need to start focusing on the eGFR to make sure that our metformin is stopped where it needs to be. And the risk of hypoglycemia increases as the renal function declines because the excretion of these medications and insulin is reduced because of the poor renal function, and thus there is a high chance that the patient might have a risk of hypoglycemia.
सर साउंड थोड़ा बोल रहे हैं, बढ़ा दीजिए.
Am I audible? So should I repeat it again?
कहाँ से वेबसाइट?
Target blood pressure of 130 by 80 mmHg, and anywhere above that should not be our targets. Maybe for general patients we try to keep it around 140-90 as our target, but for CKD patients or DKD patients we should keep the targets around 130 by 80. And we should also keep a check on the sodium intake and the protein intake of the patient. Understand that ACE inhibitors and ARBs are the first line of treatment because they reduce down the proteinuria, and that is very helpful in DKD. And we should but keep a check on the potassium levels and should monitor for hyperkalemia every time. We can add diuretics, but again, looking at the potassium, we need to assess the diuretic that we have to give, and we can add a calcium channel blocker if needed. What exactly we are trying to show here is what the RAS activation effects in DKD happen and why we are working on ACE inhibitors and ARBs. Because as we see in this graph, the vasoconstriction, sodium retention, fibrosis and proteinuria, the relative impact is on the higher end, and so is the fibrosis and the rise in BP. The role of of RAS inhibition, it reduces the proteinuria and slows the GFR decline. And it is indicated in both normotensive and hypertensive patients with albuminuria. But the dosage needs to be titrated according to the age and the blood pressure of the patient. But make sure that you avoid dual RAS blockage and monitor potassium and creatinine every time. The newer therapies in DKD, the latest one after dapagliflozin that we have seen is empagliflozin. And in the study that was EMPA-RED, we found out that empagliflozin is far superior in when compared to dapagliflozin, in the sense that DAPA can be only given till the time the eGFR is till 45, but empagliflozin is still given till the eGFR is 30 or maybe even till 20. The SGLT2 inhibitors, they reduce albuminuria, they have a great cardiovascular protection, but we need to make sure that all these patients are properly hydrated, because if you do not hydrate these patients, they will come to you with urinary tract infections, and if those UTI keep happening recurrently to these patients, you should suspect an SGLT2 inhibitor being the positive agent, and we should stop that medicine immediately. The GLP-1 receptor agonists such as liraglutide, or as now the newer ones have come, that is semaglutide, they are great medications in DKD, and now the latest one that has come 2 to 3 days back is tirzepatide or Mounjaro that we have read in the newspapers. That is a GIP and GLP-1 receptor agonist, which has a much better efficacy in weight loss and in diabetes control. But again, it comes with a lot of other side effects and thus needs to be assessed and given accordingly. And finerenone is a non-steroidal MRI with renal protective effects and can be given as an adjunctive to the other treatment that we are giving. Now, this graph shows the benefits in DKD of SGLT2 versus GLP-1, where the yellow line is an SGLT2 and the GLP is orange. We are able to understand that there is a greater cardiovascular protection, renal protection, glycemic control and BP reduction in SGLT2, whereas there is a massive weight loss in GLP-1 receptor. So thus, if we have to choose between SGLT2 and GLP-1, no matter how latest the medications are coming, we can and we should use SGLT2, but make sure that the patient is hydrated, because that is very important. Now, lifestyle and supportive measures. A protein intake of 0.8 gram per kg per day in CKD grade 3 to 5. Sodium restrictions to less than 2.3 grams per day. Smoking and alcohol cessation, weight control and exercise. And most importantly, we have to avoid nephrotoxic drugs. There's so many patients that are coming to our centers just because they take NSAIDs without restrictions and then they just turn up with CKD. Now, monitoring and follow-up is very important, and thus we have to monitor HbA1cs, eGFR and UACR every 3 to 6 months. I would like to add that once in a year or maybe every 6 months, we should advise an ophthalm checkup for these patients. Because we are checking for nephropathy, we should also check for retinopathy. And we have to address medications as the renal function declines, and we have to educate patients on symptoms and complications, because there's many times nowadays patients self-medicate, they do not even consult the doctors that their sugars are on the rise, and they might take a double dose, they might take a triple dose, they might take doses that are way above their maximum limits, and that might lead to more complications or sudden hypoglycemia. When to suspect a non-diabetic kidney disease is when there is a very rapid decline in renal function. You have to understand that a diabetic kidney disease is a silent, slow killer. It is not going to happen overnight. It is not going to happen that today the eGFR is 60 and the next month it is coming down straight to 50. It is going to happen in a slow and a steady way, and we have the chance to make sure that we can revive that eGFR, get it back to its normal self, and try to avoid this diabetic kidney disease as much as we can. And thus, if we see a rapid decline in renal function, we should stop thinking about diabetic kidney disease and we should start thinking of other causes that can lead to a CKD. If there are any active urinary sediments such as RBC cast, we should start suspecting towards any glomerulonephritis or any acute renal failure. Absence of any diabetic retinopathy is surely one of the signs, a rapid decline in GFR, but there's a absence of diabetic retinopathy in the patient. We should stop looking towards diabetic kidney disease. And if there's a heavy proteinuria but with a preserved GFR, again we should start looking towards complement issues. And small kidneys on ultrasound, again in diabetic kidney disease, we will not see very small kidneys in the body. It is just the functioning that will get hampered. It is just the nephrons that we are losing, and it will not shrink to small size kidneys. Generally, what we do is we try to treat the patient as much as we can, and we make sure that the patients are in their well-being. But if the eGFR is again reaching 30 ml per minute per 1.73 meters square, we should now shift the patient to a nephrologist and make sure that the patient care is given properly so that the patient's kidneys are saved, the story towards dialysis is safe, and we can make sure that the patient survives for a long period of time. When there's a rapid progression of CKD and when there's persistent macroalbuminuria or a resistant hypertension, we should refer this patient to a nephrologist. And if the patient is planning for any dialysis or transplant, we should definitely refer the patient to a nephrologist. The prognosis of these patients, early DKD may be reversible or stable with treatment. There are so many patients that we see throughout the months. They have a stable eGFR of 80, 70, and they are doing completely fine with it. And once you try to stabilize this eGFR to somewhere around 70, 80, they remain that way for another 5 years, maybe 10 years. It depends on the control of the patient. And so progression to ESRD can be delayed significantly. Cardiovascular disease remains the leading cause of mortality in DKD, but again, patient adherence is crucial. To summarize the CME, I'd like to say that DKD is common and it is a serious disease globally. Early detection and control of risk factors are essential, and if there are early detection, the patient can have a reversal or a stable treatment can really help survive that patient for a long, maybe 20, 30 years. Newer therapies have improved outcomes, and multidisciplinary care and education are the key. Thank you so much.